In this video, we're going to talk about second degree type 2 or Mobitz II blocks. And I do have an example here for us to kind of start off. So in order to take a look at this, we'll go through our 5 steps of ECG interpretation. I'm not going to go through the rate, but we will talk about the rhythm. So if we look here, we know we have an irregular rhythm. This is actually irregularly irregular. What that means is there's no predictability. Here we've got 4 QRS complexes followed by a break. Here we've got 3 QRS complexes followed by a break. So again, there's no predictability to our rhythm. So it is irregularly irregular. Next piece we know we're going to look for is our P waves. We're going to take a look and see if we have P waves, and we do. So we have actually fairly consistent P waves here. So we can see P waves across the majority of the strip. A couple of things you're looking for is do they look the same? And they do, which tells us that they're probably all coming from the SA node and then traveling down to the AV node. There are some things to note as we're just looking at those P waves. Some of them don't have QRS complexes. So we actually have a few here that do not have QRS complexes, which we will note further. So P waves, yep, we do have P waves. And then we want to look at our PR interval. And we're starting to think probably here that we have some sort of block. So one of the things I want to be really mindful of is the length of that PR interval. And is it the same? Is it lengthening? So we're usually looking at around 5 to 6 small boxes, which we have here. And it's fairly consistent. We're actually not seeing any lengthening or progressive lengthening. So PR interval, yes, we have one, and it is fairly consistent. The last piece here would be QRS complexes. And do we have them? Sure, we do. So we can see that throughout we do have some QRS complexes. They are narrow here, and most of them are preceded by a P wave, but we do see some areas where we have a drop beat or there is no QRS complex, and we want to be mindful of those areas. So there are a few places here where we have no QRS complexes or we have some drop beats. So QRS complexes, yes, but some drop beats, and that is going to be important. What does that tell us? We've got an irregularly irregular rhythm, okay? We have P waves, yes. We have a consistent PR interval, but sometimes those P waves are not generating QRS complexes, and that's what tells us it's a second degree type 2 or Mobitz II block. So there's no predictability to where we're dropping a beat. So we can't use a lengthening PR interval to say, hey, I know when the next drop beat is going to come. But we are dropping beats. So the impulse is generated from the SA node because I see normal P waves. I've got generally, or most of the time, a normal PR interval. So it's generating from the SA node, it's traveling through the AV node, but sometimes, most of the time, it's traveling down through here and generating an impulse, but sometimes it's not able to pass that His-Purkinje system and generate a QRS complex. So that is what's causing us some drop beats. And we can talk about what's causing that. And the big thing to remember here is that we're looking at conduction through the His-Purkinje system, which is going to use fast sodium channels that work on an all or nothing basis. That's the big reason, and that's a big difference between a second degree type 2 block and a second degree type 1 block is our second degree type 2 block is up here. It's in the AV node where we use L-type or slow calcium channels to generate an impulse. Whereas our second degree type 2 is lower down. So it's lower down, usually somewhere in the His bundle or the bundle of His system that's leading to the inability to move an impulse. So it could be at the exit of the AV node, could be through the bundle of His. Whatever it is that's happening is the impulse cannot or gets to a point where it cannot generate. And again, the reason for that is that we're looking at an issue with an all or nothing conduction system. So let's look at what the action potential looks like through our His-Purkinje system. So these cells can have some automaticity. They do have IF funny channels in them. So their IF funny channels would look something like this. We've got an IF funny channel. But when we look at the action potential or what the action potential primarily looks like in the His-Purkinje system is we're using our fast sodium channels. So they work on an all or nothing response. You can see that here because we have a very definitive threshold potential through which they're going to fire. And that is just simply a fast voltage gated sodium channel. So we're looking at voltage gated sodium channels that fire once we hit a certain resting membrane potential. Once they hit their peak or their threshold, we start to see potassium and calcium channels open. So that is what's going to allow for our plateau phase. We have our plateau phase, and then we have our repolarization, which is primarily going to be driven by potassium. So we got potassium working here. But the big thing that we have to remember, or the big thing that we're looking at, is that we have impulses in this system that are generated by voltage-gated sodium channels, and they are fast channels that require an all or nothing threshold. So they require an all or nothing response. So what that means is we can't generate enough energy to create that all or nothing response and then sustain it through the conduction system, then we will not have an action potential. So if we can't generate that, then we won't have an action potential, which can create the problems that we see for someone who might be having a second degree type 2 or Mobitz type 2 block. The most common thing that's happening here is ischemia. We look at someone who's having, say, myocardial infarction, or they're having a secondary type 2, they likely have some sort of ischemia. So whether that's new ischemia or old ischemia, it doesn't really matter. But something is impairing the function of the ion channels in this system. What we're seeing is that we have an area of the system that's damaged. So that could be ischemia, could be progressive structural damage to the area. It doesn't really matter, but something is impacting the ability of these ions to function, or the ion channels to function the way that they should. So we'll draw a cell in this area. So this is a cell from this kind of area here. And we'll say that ischemia is the primary problem. So this cell has some ischemia to it. And what that means often is that a couple of things are not working properly. If the cell has ischemia, what that usually means for us is that our sodium potassium pump is not working particularly well. So if this is our sodium potassium pump, we know that its job is to pump out 3 sodium. So we should see 3 sodium being pumped out, and we should see 2 potassium being pumped in. This is ATP mediated, so we require ATP for this to do its job. And if this patient is experiencing ischemia, then what we're going to see is that is no longer going to function. So with that ischemia, we start to lose function of our sodium potassium pump. So ischemia is going to decrease function. And we can think about a few of the consequences we're going to have there. One is that we're going to start to see an increased concentration of sodium inside the cell. So we start to see an increased concentration of intracellular sodium. Remember, sodium should be our primary extracellular ion. The other consequence we're going to see is an increase in extracellular potassium. So we haven't had full repolarization, or what's going to happen is we're going to start to impair the return to resting membrane potential, or to normal electrochemical gradients. So what that means is by the time the next impulse comes around, I may have less sodium outside for influx into the cell, and less potassium inside for efflux out of the cell. And what we know is that the way in which we have an action potential here is through opening these voltage-gated sodium channels and allowing for big influx of sodium into the cell. That's what's driving our action potentials forward. So if we are not having this return to normal electrochemical gradient, and we cannot allow for this large movement of sodium into the cell, then we can get to a point where we do not reach that all or nothing response. And what we see here is a little bit different than, say, the AB node, where what will happen is every impulse leads to worse and worse refractory periods, and we just get slower and slower. That doesn't happen in the His-Purkinje system. Every impulse, if it can generate an all or nothing response, it will travel through. So even if this is leading to, so this is our impulse coming down from the AB node, if that impulse being generated is going to lead to sodium entering, it's going to lead to potassium leaving, and if our sodium potassium pump isn't working, then sodium concentration inside will get worse, potassium concentration outside will get worse. It doesn't really care about how much worse it is. All these cells care about is, can they generate this all or nothing response? So instead of seeing progressive worsening or a lengthening PR interval, we do not see that. The impulse will travel through, will create a refractory period, or will move ions, which can make these things worse. So the sodium potassium pump's still not working. We're still seeing an increase in intracellular sodium and an increase in extracellular potassium, and that will only worsen with each subsequent beat. We have another impulse travel, and it will do the same thing. So another impulse comes down, travels down through here, is going to do the exact same thing, worsens some of this refractory because now we have even more sodium inside the cell and even more potassium outside the cell. Eventually, where it gets to the point where this impairment in the electrical chemical gradients is too severe in order to have an action potential. So we will see worsening until impairment is too severe to have all or nothing. That all or nothing response is really the key here, is that we won't see progressive damage or dysfunction, even though that might be happening. With every impulse, this area that is ischemic is having a harder time clearing sodium from the cell, having a hard time increasing intracellular potassium levels. We won't see that getting worse because it's all or nothing response. As long as we hit the tipping point or hit that all or nothing, we'll generate an impulse. And that's what we see, is impulse after impulse after impulse with no sign of problems until eventually we get to the point where this impairment is too severe and we will no longer have an impulse and we drop our beat. How long that takes can vary. It depends on how quickly after we're no longer having an impulse, we're having this rest period, we can clear those ions and make them function better. You can see here we dropped 2 beats in a row, so clearly a longer rest period is needed before we can kick back in and have our impulse. A couple other things that we can think about when we're looking at ischemia as an example is that eventually we're going to change our resting membrane potentials. So over time, if this ischemia is happening, we are going to see an increase in resting membrane potential as the cell becomes more positive. So as we have more sodium inside the cell, more potassium outside the cell, resting membrane potential goes up, and we actually start to close our sodium channels. So that can lead to even worsening of our all or nothing response. So we could end up dropping more beats. The cell will begin to swell. So because we have an increase in intracellular sodium, we actually start to see more water entering the cell, which can disrupt our gap junctions and make it harder to have that impulse travel along the conduction system. So if we start disrupting those gap junctions that are throughout the conduction system, it can be harder of the impulse propagate down the conduction system, making it even worse. So these second degree type 2 blocks can very quickly progress towards bradycardia if we are seeing just worsening symptoms. The ischemia is getting worse. We're seeing a much higher resting memory potential. We're not able to clear our sodium and put our potassium back. We are disrupting our gap junctions. If that's going to consistently get worse, we can start dropping more and more beats as we aren't able to get back to normal in order to have that all or nothing response.